Welcome to my presentation on chronic pain. Specifically, I'll talk about the Neuromatrix Theory and its implications for chronic pain treatment. After briefly discussing pain and the neuromatrix, I'm going to outline the physiological and psychological consequences of chronic pain and give a brief history on the evolution of pain theories. I'll then provide more detail on the Neuromatrix Theory and its implications for the treatment of chronic pain. I'll finish this presentation by summing up with conclusions on this research. It's important to point out the definition of pain varies significantly. According to Melzack and Katz, 2012, pain is a subjective and personal experience influenced by factors such as cultural learning, the meaning of the situation, attention, and other psychological variables. Despite easily understood, beneficial psychological aspects of pain, such as indicating injury or disease and danger to body tissue, the complex issues of chronic pain provide a challenge to understanding the puzzle of pain. Pain can no longer be considered an accurate informant of what is going on in body tissues. In comparison to acute sensory pain, chronic pain is difficult to explain because it's often characterized by severe pain, associated with little or no injury or pathology, and also with psychological and physiological stress. The Neuromatrix theory of pain proposes that pain is a multidimensional experience produced by characteristic neurosignature patterns of nerve impulses generated by a widely distributed neural network called the body-self neuromatrix in the brain. It has important implications for research and therapy. This research aims to highlight how the Neuromatrix theory provides an approach that helps examine and understand the complex issue of chronic pain, and how the objective of treatment should now be geared towards a multidisciplinary approach, with an emphasis on the psychological aspect of treatment. So what are the consequences of chronic pain? Well, physiologically, the effects of chronic pain include changes in the pain pathway, resulting in continued presence of pain, even in the absence of an exciting cause. Amplification of pain signals, exaggerated pain sensation, allodynia, which is pain in response to a non-painful stimulus, an alteration of immune activity, the sympathetic nervous system activity, and the hypothalamus, pituitary, adrenal axes. Psychologically, chronic pain commonly causes anxiety, depression, sleep disturbance, social withdrawal, financial burden, and a reduced quality of life. It also decreases processing capacity and slows decision making. As you can see in Figure 2, various risk factors have been identified for chronic pain, such as genetic, environmental, and personality factors. So you can see, getting back to the point made earlier about pain no longer being considered an accurate informant of what is occurring in the body tissues, this is because of these factors. So simple things like a person's personality, whether they're pessimistic or neurotic, for example, whether they have high anxiety levels, for example, all of these things can contribute to pain being different for each different person. This was very different to how pain was considered in the past. When looking at the evolution of pain theories, Descartes' specificity theory stated that pain was considered to travel in a direct line from sensory pain receptors through a pathway in the spinal cord to the brain. The psychological effects of pain, such as anxiety or past experience, were not considered at all. Often patients with pain that didn't show any sign of disease were sent to psychiatrists and considered psychologically disturbed. The pattern theory of pain included a lot of different theories. Each of these was considered to have insufficient explanations. For example, Goldscheider's 1894 proposal was of a central summation in the dorsal horn as an important factor in pain, and Nordendos in 1959 proposed the inhibition of small diameter fibres by large diameter fibres. None of these theories sufficiently identified the role of the brain. However, they did move the pain theory into the spinal cord and away from the periphery. The gate control theory proposed by Melzack and Wall in 1965 emphasized a gating mechanism in the spinal dorsal horns as a modulator of inputs and identified the brain's central processing role in pain. This was significant because it was the first theory of pain to actually do this. Psychological factors were considered to be an important part of pain processing, and the result was new psychological therapies for controlling pain. However, a major inconsistency with this theory was its failure to explain phantom limb pain. Figure 5 shows the factors that contribute to the patterns of activity generated by the body self neuromatrix, which comprises sensory, affective, and cognitive neuromodules. The output patterns from the neuromatrix produce the multiple dimensions of pain, experienced as well as concurrent homeostatic and behavioural responses. So what is the effect of the neuromatrix theory of pain? The neuromatrix is a large network of neurons consisting of loops between the thalamus and cortex, and also between the cortex and limbic system. Its output pattern affects homeostatic and behavioural responses after injury or chronic stress, as was mentioned in Figure 5. As a result, pain occurs from the output of the neural brain network rather than as a result of sensory input from injury or inflammation. This neuromatrix therefore generates neural patterns that result in pain. With regards to pain production, genetic contributions and the neural hormonal mechanisms of stress are considered as important as sensory neural components. The spatial distribution and synaptic links of the neuromatrix are determined genetically and later modified by sensory experience. The theory proposes that enhanced efficacy of the synapses of the pain neuromatrix contribute to chronic pain because less input is required for pain activation. So what are the implications of the neuromatrix concept to treatment? Well, firstly, phantom limb pain and allodynia can be explained as a result of the qualities of experience originating in the neural networks of the brain. Psychological treatments such as relaxation, hypnosis, and behaviour modification have now become an important approach to chronic pain treatment. Pain physiology education is now considered effective for changing pain cognitions and improving the health status in patients with chronic pain. The therapeutic aspect of this approach is on reducing the sensitivity and activity of the pain neuromatrix via reduction of the threat. Physiological methods of treatment should be expanded to include endocrinologists and immunologists because immune and endocrine-driven threats contribute to the increased diversification of inputs that can activate the pain neuromatrix. In conclusion, pain is more than the body's response to acute injury because it results from subjective brain experiences occurring both independently and dependently of sensory inputs. Explanations of the complexity of chronic pain have evolved with the neuromatrix theory and a greater understanding of the brain's role in pain. A goal of future development of this theory lies in the implementation of successful, individually based treatment methods for chronic pain. New treatment approaches, including education about human physiology and comprehensive therapeutic recovery plans, will further evolve with greater understanding of the brain's complexity. Basically, the future of pain lies in the understanding of the brain.